Welcome to the 8th module in this educational series, where we will explore issues related to the forecasting of blood requirements, the planning necessary for the blood donor recruitment program, and how to allocate an appropriate budget. By the end of this module, you will appreciate the different ways in which blood needs can be estimated and how to select the method most appropriate for your setting. You will understand how to develop a costed blood donor recruitment work plan that meets these needs and sits comfortably within the broader strategy of your organization. One may ask, why do we need to estimate or forecast the blood requirements? In a WHO Global Consensus Meeting report of 2010, it was noted that national planners and providers of blood for transfusion need to know how much blood is required for their populations and where and when it is needed, so that blood is neither under or oversupplied. If the blood supply is inadequate, then this may result in the death or disability of patients requiring a blood transfusion. On the other hand, a surplus of blood may result in the outdating of blood products, which represents a waste of resource that is both expensive to produce and donated in the expectation that it will be used. Furthermore, the supply of blood should be equitable such that access to blood for transfusion is irrespective of age, gender, or socioeconomic status. It follows from this that forecasting of blood requirements is critical for the effective management of a country's blood program. We need to satisfy the routine and emergency needs of a country's healthcare system in a timely and equitable manner. Accurate forecasting will allow the allocation of appropriate resources to ensure that there is sufficient blood provision. An inaccurate forecast will not only be potentially wasteful of time and money, it can harm the reputation of the blood establishment. Donors and other stakeholders will look poorly upon an organization that allows shortage or lets valuable blood time expire. The World Health Organization requires each country to be able to estimate its own needs for blood and blood products. Increasing in granularity, these national blood forecasts can cascade to estimates for each region, province, district, and individual health institution. This will ensure that current and future arrangements for optimal blood provision can be made so that no patient in need of blood will be deprived of this life-saving intervention. If there is a good forecast of blood needs, this will inherently assist in systematically planning blood collection and donor recruitment, so avoiding an excess or a shortage. As you will be aware, blood and blood products have a limited shelf life, and therefore the risk of shortages or overstocking is high if due diligence is not properly exercised. This places a huge demand on the blood service to have effective blood supply management systems. Despite the long-standing recognition of the importance of accurately forecasting blood transfusion requirements, progress in the development of practical methods to do so has been slow. This partly explains why, globally, there are frequent reports of inadequate blood supplies, especially in low and middle-income countries. The key elements in determining national requirements include the current use, current demand, and the population need. The graphic on this slide is reproduced from a report arising from the WHO Experts Consultation on Estimation of Blood Requirements. It shows the relationship between population need, current demand, and current use of blood for transfusion. We will briefly discuss each of these components. The current use of blood for transfusion is the number of blood units utilized by a given number of facilities over a defined period of time, usually 1 year. The current blood use reflects disease burden, health services offered, access to health care, and prescribing practice that may include inappropriate transfusions. It also, however, reflects whether blood is actually available. If it is not, current use will not be a good proxy measure for demand. The current demand is calculated in a similar manner, but its basis is the number of whole blood units required to meet all confirmed requests for blood transfusion, both for emergency and elective procedures. Thus, current demand is not directly affected by inadequate supply. The population need is the number of whole blood units that will be sufficient to transfuse all individuals who require a blood transfusion in a given population, usually a nation, over a defined time period, which is usually 1 year. Importantly, this assumes universal access to healthcare services, whereas the reality is that in many poorer countries, access in rural areas can be problematic. Within populations, the need for blood will have a special component as disease burden and population density is likely to be heterogeneous. Recommended reading for a deeper understanding of these issues is a paper by Bakary et al., published in the Transfusion Medicine Review Journal in January 2018. This paper is titled Estimating Tanzania's National Met and Unmet Blood Demand. It will help in appreciating how different blood services are approaching the blood requirement issue. Understanding the clinical drivers for transfusion is helpful for forecasting the blood needs of the nation or a region. These clinical drivers of demand will vary within and between countries. They include, but are not limited to, epidemiological, ecological, geographical, socio-economic, and health system factors. As we have previously seen, the pattern of blood use differs between developed and developing countries. In resource-constrained settings, blood is usually needed for complications during pregnancy and childbirth, severe childhood anemia, and trauma. The trauma needs may emanate from conflicts, disaster, violence, and road traffic accidents. In contrast, in the developed countries, the blood usage pattern is driven by complex medical and surgical procedures such as cardiac, vascular, neuro, and transplant. To better understand the pattern of blood usage, blood establishment staff need to interact with relevant personnel within the health institutions served. To ensure an adequate blood supply is the primary responsibility of a blood service, especially the blood donor recruitment function. The supply needs to be continually adjusted to actual needs. Many developing countries have regular blood shortages. The reasons for this are many. For example, the absence of a well-organized blood donor program may result in insufficient donors coming forward. This may be chronic or seasonal. Conversely, more stringent safety measures may reduce the population eligible to donate and result in more deferrals. The WHO Global Consensus Meeting in 2010 concluded the following. It became clear that it was extremely unlikely that a simple one-size-fits-all model or formula could predict blood transfusion requirements in all settings. As such, it was felt that a more appropriate output will be the justification for and description of a variety of approaches in a toolkit. The key task for a blood establishment is to identify the tool appropriate for their setting. There have been various methods or models promoted over the years by the WHO that can guide blood services in forecasting their blood requirements, and we will shortly describe some of these in more detail. Note that some may provide different estimates for the same setting, so a judicious approach in selecting the appropriate method is needed. One method that can be employed, although more suited to modern healthcare services, is based on the number of acute hospital beds. When first recommended by the WHO, a figure of 6.7 units of blood per bed was indicated. A units per admission calculation can also be applied. There are several limitations on the use of this model, as over time, there has been a trend towards providing outpatient department treatment, which then reduces the relevance of number of hospital beds as the driver of healthcare. Also, the number of hospital beds does not depend on the size of population, and hence is not an appropriate indicator for estimating and forecasting future demand. It is also important to note that hospital beds may be used for patients with complex disorders with different levels of blood consumption. Hence, the average blood estimation may mask significant variation. For example, depending on the specialty of the healthcare facility. A second approach is to forecast using the country's or region's population. The percentage basis has varied over time, as well as by whether a high or low income country is being considered. However, 2% is a fair average. This formula can be used to calculate the blood requirements of individual regions or districts within the country. It makes it possible to compare between countries or regions of similar size and project the trend in requirements in the context of population growth or decline. To illustrate the application of this model, let us consider a country with a population of 10 million citizens. The blood forecast can be calculated by multiplying 10 million by 2%. which gives us an estimate of 200,000 units of blood per year, or approximately 3,850 units per week. A minimum of 100,000 blood donors will be needed if we presume that each donor gives blood at least twice per year, more if the average is lower. A third approach, and probably the most widely used, is based on extrapolation of historical blood usage data. This requires assessment of the number of units of blood used in a specified period in a defined geographical area or population. It is important to analyze over time to give an indication of whether the demand for blood is constant, increasing, or decreasing. This trend line can then be used to determine the forecast for the following year, adjusted for a range of known factors that may change the transfusion landscape in the next period. Some blood services may use previous year's blood collection as the basis, or there may be an attempt to use the actual transfused data to arrive at an estimate. As discussed previously, one will need to consider the unmet blood demand if using either of these approaches. In most cases, there will be internal wastage to consider. Also be aware that not all blood that is provided to hospitals will actually be used. The methods shared so far are not the only ones available. There are many approaches used around the world, applicable in different settings and according to the analytical capabilities of the blood establishment. Some of the forecasting methods used are informal, where forecasting is intuitive and depends on individual experience and abilities. The challenge of having an undocumented method of forecasting is that it limits the ability to continuously improve forecasting capacity, so should generally be considered undesirable. There are additional formal forecasting methods which can be used. These may employ qualitative techniques such as Delphi and market surveys. One can further research these methods, so they will not be presented in detail here. They can also be useful in settings where there is limited historic data, though this will not normally be the case when considering demand for blood. Quantitative techniques which can be applied include advanced statistical models such as autoprojection, moving average, exponential smoothing, causal, regressive, Box-Jenkins, econometric, and input-output. The existence of these different forecasting mechanisms should not overly concern blood donor recruitment staff, but it is useful to understand that blood estimation is a process that requires interaction with multiple stakeholders, both within the blood service as well as with health institutions that conduct the actual blood transfusions. It is also helpful to appreciate that, globally, there is no universally applicable approach, but rather a toolbox from which each blood establishment is free to select the appropriate tool for their setting. Finally, we look at the global context of blood forecasting based on the WHO indicator data on whole blood donations per 1,000 population. As previously observed, the WHO recommends a minimum blood collection threshold of 10 whole blood donations per 1,000 population as an indicator for blood self-sufficiency in a low-income country or region. Based on 2013 WHO mapping, many developing countries have whole blood donations below the threshold level. However, the implications of this will depend on the specific country or regional level context. We conclude this section by pointing out that blood needs forecasting can be done for varying time periods based on myriad considerations. A short-term forecast would typically cover 1 to 2 years. In a stable, mature system, such forecasting is best done by simple techniques based on historical data, professional judgment, and constant communications with hospitals. But very short-term tactical forecasting at monthly, weekly, and even daily levels is highly desirable, since this will help avoid both shortages and overcollection. In long-term forecasting, normally looking 5 to 10 years ahead, the key considerations for strategic planning are demographic changes and evolving healthcare strategies. Once there is a forecast for blood demand, it is then important for the recruitment function to plan to mobilize sufficient donors and manage them for the lifetime of their relationship with blood donation. The old expression, "If you fail to plan, you plan to fail," indicates the importance of this activity. The following slides will talk in general about the planning process. There will then be some examples taken from Zimbabwe's donor recruitment plans. The graphic shows the top-down nature of the strategic planning process. Compared to a commercial business, the vision, mission, and values are relatively straightforward for a blood establishment to articulate, but these do need to be shared and clearly understood across the organization. The donor recruiter will mostly work at the tactical level, translating the needs of the organization into actionable programs that will help meet the forecast demand for blood. Therefore, the planning for all donor-related activity needs to be done within the context of the overall blood service planning framework. The starting point is the blood services strategic plan, which typically looks 3 to 5 years ahead. The strategic plan is a little like a jigsaw puzzle, where all the pieces, including donor-related activity, must be in the right place to complete the picture. The strategic plan will typically deal with the big themes of delivering blood to patients, but there must be a clear line of sight between day-to-day activity and an organization strategy. From the strategic plan can be derived an annual work plan, similar to the earlier discussion around forecasting. Such plans can be broken down into quarterly, monthly, weekly, and daily activities. For blood donor recruitment and management, the strategic plan will generally cover high-level issues such as forecast blood demand and ambitions for such things as the size of the donor base, while an operational plan will target groups, detail publicity and communication approaches, and so on. This related model helps us to recognize planning as a cyclical rather than a straight-line activity. In the first phase, we identify the problem or opportunity which blood donor recruitment, retention, and management activity can help resolve. Ways to approach this are through desktop research, performance reviews, gap analysis, hospital need assessments, and knowledge, attitude, practice, and behavior studies on blood donors. Not all the activities need be done solely by the blood donor recruitment staff. It is desirable to work with the entire transfusion chain. Stage 2 identifies all the strategic issues and primary objectives pertaining to donor recruitment and related activity. What is the challenge? Key performance targets might also include such things as 90% of set target blood collections met, 90% positive feedback from blood donors, and 80% repeat blood donations. You will also need to consider what resources are needed to be able to mobilize and retain sufficient numbers. In the design stage 3, it is important to define the approaches that will be pursued so that the recruitment function objectives are met. So, for example, what proportion of demand will be met through community blood drives and what through hospital-based or other fixed collection facilities? What communication strategies will be used to inform and educate donors? In stages 4 to 6, activity needs to be not just implemented, but carefully monitored to understand to what extent expected outcomes are being achieved. Finally, remember to keep stakeholders informed. This figure illustrates how the donor-focused activity should be integrated into the overall blood program coordination framework. It is important to note that a support framework is needed for the blood donor recruitment function, as for others. This includes a quality management system, as well as data management, research, and ICT resource provision. Monitoring and evaluation will be covered in detail in Module 11. However, it may be helpful at this stage to further emphasize the connectivities between planning, implementation, and outcomes. If outcomes are not being achieved, then corrective action needs to be taken. Organizations will typically use M&E feedback for evidence-based reviews at half-yearly or quarterly intervals, enabling cycles of continuous improvement. In this slide, and those that follow, some planning tools and approaches adopted by the National Blood Service Zimbabwe will be presented. Planning is a complex area, and so, while not possible to give a detailed and exact template that should be followed, it should be possible to take the generic principles and develop something suitable for your organization. So, here, we see a simple logic model for blood donor recruitment. A logic model, in this context, is simply a graphical depiction of relationships. In developing a logic model, there is need to define the problem statement and identify the inputs, activities, outputs, outcomes, and impacts of the blood donor recruitment program. A good logic model should also reflect agreement among major stakeholders about intended implementation and outcomes, generally referred to as a planned logic model. We have seen that many blood services in low-income countries have a strong focus on school-based collection. Because over-reliance on this approach can lead to seasonal shortage, it is important to plan a diverse range of sites for blood collection activity. Here, we see that, as well as schools, Zimbabwe embraces faith-based organizations, businesses, army camps, etc. Different locations will engage different audiences, and identifying these sites at the planning stage is helpful for developing approaches to effectively engage each target group. In Zimbabwe, the blood program is differentiated by a three-tier system based on age: school children of 16 to 20 years, youths of 21 to 30 years, and adults defined as 31 to 65 years. Motivation and communication needs are considered different for each age segment, and operational plans are developed for each group. You may prefer to segment your donor base by geography, tribal affiliation, or some other criteria. To illustrate our discussion, let's look at the age profile of Zimbabwe donors based on an internal analysis report. The figure provides details about the average distribution of the blood donors over the period 2013 to 2018. There are a number of key planning questions that emerge. How can we increase youth and adult blood donations? What strategies should be pursued during school holidays when stocks are likely to fall? What are the key incentives for boosting and maintaining high levels of blood donation in each age group? The planning exercise should then be tasked to consider and formulate strategies to address these key issues. For example, this graph shows the problem of periodic blood shortage during school holidays. Planning needed to address this issue, and the resulting Pledge 25 Club activity is discussed in Module 7, which looks in detail at youth blood programs. The key challenge for donor recruitment and management staff is to avoid shortage or excess blood products. Therefore, it is essential to be able to readily understand whether activity should be scaled up, maintained, or scaled down. This is Zimbabwe's approach to decision-making in this area. The overall blood management status comprises the level of blood stock in quarantine, units available, and the outstanding blood orders versus blood supplies. The National Blood Service Zimbabwe has widely presented its operational research on blood supply management status. Fundamentally, the foundation is a color-coded inventory management system that provides the overall blood supply management status based on the three key measures. These are quarantine, available, and order/supply data. More details on this alternative system will be shared in the monitoring and evaluation module. In this figure, you will notice that in 2016, the National Blood Service Zimbabwe managed to keep a national stock cover of at least 5 days, around 74% of the time. The individual data for each of the 5 regional branches is shown. This is critical information for the planning, the recruitment, and management of blood donors. Relatedly, there is a global good practice trend where various blood services publish blood stock information on their website. On the slide is a screen grab of that day's status posted by the South African National Blood Service. It can be noted that the blood groups B negative, AB negative, and O negative are below the desired threshold. Also, the platelet stock levels are shown at 0.3 days. This kind of data sharing and availability not only shows openness and accountability to the community shared internally, it also helps the recruitment function to proactively plan for the maintenance and restocking strategies of the blood bank. This is information that the blood recruitment function should consistently demand from their laboratory so that there is evidence-based recruitment practice. On a daily basis, you need to know where and when you will be going to collect blood, and This is the operational work plan. How you structure your work will have a number of dependencies, but there are elements common to all. Plan ahead as far as possible. Ideally, this should be 6 months or more. You may find it helpful to create a visual planning tool to help you track and anticipate activity. In general, you will want to return to good performing panels as often as possible, or at least as often as they are willing to engage. But where collection sessions or panels are not performing well, consider combining with others, or perhaps replacing entirely with new collection locations. You need to balance recruiting to fill existing sessions with the business development activity of searching out new opportunities. This is something too often neglected by overstressed recruitment staff. Downstream from forecasting, but as part of the planning cycle, it is important to have the corresponding budget that supports the implementation of planned blood donor recruitment activities. Recruitment is typically a cost center or spending department. That is to say, there is, in most cases, no need to consider revenues. Blood donor recruitment costs, together with all other expenses in the blood establishment, contributes to the overall cost of a unit of blood. Extensive evidence on cost has been documented by Karina Tal under the K4D project. Depending on which of the 3 types of blood donor we're dealing with, that is, voluntary, unpaid, paid, and family replacement, the recruitment drive cost will differ and hence have to be budgeted for accordingly. It is commonly assumed that voluntary donation, being by definition unpaid, will be the least expensive of the various approaches. However, this is in most, if not all cases, untrue. It costs a great deal to place collection resource in locations where people find it convenient to donate, and persuading the public to give needs considerable investment. Whether revenue is generated by the sale of blood, received as a government grant, or in some other form, typically, senior management will determine how available funds are allocated to departments. In practice, there is a process of negotiation, but most commonly adopted is one of 2 core approaches. Incremental budgeting involves taking last year's figures and making some adjustment for inflation. This is probably the approach most commonly used, but a weakness is that it encourages staff to spend all of the money budgeted, even if doing so is not productive, and so can lead to wastefulness. It also assumes a situation where we will always do what we have always done. This can easily stifle innovation within a department and is something to guard against. The alternative, zero-based budgeting, effectively starts each accounting period with a blank sheet of paper. All proposed activities must be justified. Focusing on voluntary donation, here are listed some of the key cost categories that will typically be seen as line items in a recruitment department's budget. Where there is a significant proportion of collection generated from mobile collection sites, costs for vehicles, fuel, and maintenance will be high. Staff will need to travel in advance of collection sessions to organize and mobilize donors, and perhaps again afterwards to confirm test results. The more sophisticated the approach, the higher the costs. In South Africa, for example, there is a vibrant blood donor contact center with significant costs to set up, run, and maintain this tele-recruitment function. Other settings may have more modest ambitions, perhaps just budgeting airtime and data. Blood donor events may entail the hire of venues, provision of catering, and perhaps travel reimbursements, costs related to organizing meetings, stakeholder engagement, volunteer support, promotional materials, and milestone achievements will all need to be budgeted accordingly. Do you know how much it costs to recruit a donor? This is important information because without it, you cannot compare different methods of recruitment. Running a TV advertising campaign, for example, may be expensive, but if it brings in many donors, it may be better value than seemingly cheaper but less effective methods. Without understanding cost per acquisition, You cannot see if your recruitment effort is becoming more efficient over time. You also cannot compare potential investments in recruitment against investments in retention, and so concentrate on the strategy that is the most cost-effective. To arrive at a cost per recruited donor, simply take all of the department's costs and divide these by the number of donors recruited. In conclusion, blood establishments are unusual in that they do not and cannot simply pay for their raw materials. They need, in effect, to market to their suppliers in such a manner that blood of the right type and quality comes into the organization on a monthly, weekly, and daily basis. For this, a robust process for managing the closely interrelated activities of forecasting, planning, and budgeting is essential to meet patient blood needs. Dwight Eisenhower once observed what is well known in military circles, that once battle commences, a plan will be useless, but the process of having considered alternative strategies and approaches and contemplated contingencies is invaluable. Finally, please reflect on some of the concepts and approaches covered in this module. There are suggestions here for activities you may wish to undertake that will embed learning and help you better understand how your own organization tackles some of the issues discussed. In Module 9, we will look at operational excellence as a driver of repeat donation.